Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett, broadcasting from Miami, Florida. Today we have the pleasure of having Richard Mandel, MD, a spinal neurosurgeon from Tampa, Florida, who's going to be talking about the very important screening examination in neurology. We're also graced by the presence of a couple of panelists, and I'll let them introduce themselves. Welcome, Lisa. Please unmute yourself and say hi. Unmute yourself.
Hello. Hi, I'm Lisa Cornforth. Live in Bentonville, Arkansas. I'm a second-year medical student at Oceana University, and I've been shadowing a neurologist for several months, and so I'm interested in hearing today about some techniques for examining our patient. Thanks for inviting me.
Welcome, Lisa. And Simon?
Hi, my name is Simon Downs. I'm coming to you from Tokyo, Japan. I'm also a second-year medical student and a developmental psychologist.
Welcome, Simon. And as Dan will tell you, it's 2 o'clock in the morning in Japan, but you better get used to those hours, Simon.
Okay, 3:30 a.m.
Oh my goodness.
Okay, welcome, Ben.
Yep. I'm Ben Mulpuri, a physician from Michigan. I'm an internal medicine physician with health information technology background and also MBA. And I'm very much interested in these hangouts, and I'm really excited to join. Thank you.
Welcome, Ben. And Richard, it's your show.
Okay. You know, the neurological exam is really important, not just for neurologists and neurosurgeons, but for ER doctors, for everybody that admits and takes care of patients. You have to be able to have a degree of familiarity with the exam, and this is not at all the this is not at all for the reductionist mentality. You really have to think in terms of the big picture and go from a really global to granular approach. You've got to start on low magnification and gradually zoom in. But the screening examination, it's like any screening exam in medicine. You want it to be sensitive but not specific. You want it to be reproducible, and it should be inexpensive. And so think of the screening exam, and that's what you're going to build the rest of your exam on. When you go into a clinic, sorry. One second.
Yeah, it says double-click to edit.
Yeah, this is another error. Sorry.
Okay.
I thought we had that fixed. Okay, 1 second. Why?
Well, I guess, Simon, this is when our broadcasting expertise is brought into play. We have to, like in a baseball game or a football game, if there's a rain delay. You've watched the okay, go ahead, Richard. Sorry.
Okay. So here are the goals, okay? As medical students, as undergraduate students, you want to get your screening exam down to a well-rehearsed routine that you can do in 3 to 5 minutes, and then be able to represent it in an organized, brief synopsis, okay? Going into a room and spending 25 minutes with a patient doing a thorough neuro exam is really of very little practicality in a busy clinic. In the outpatient setting, you're often going to be examining people that have a complaint, and so it's a goal-directed exam. And when you're in the hospital, you're going to be admitting people with various problems, and you want to know if there's neurologic involvement and how subtle it is. So you've got to get fast at this. It's not going to help you to do in-depth neurological exams on everyone, especially if they're predominantly asymptomatic. And if in your screening exam you've done it correctly, you shouldn't need to do a long, drawn-out examination. All right, so like I said before, avoid a reductionist mentality. And the reason for that is that if you look at like your average neuroanatomy textbook, or like think of Kendall and Schwartz, the Principles of Neuroscience, you know, that's a 1,500-page book. That alone is bigger than the Gray's Anatomy book. There's more terms in neuroanatomy, and you're not going to be familiar with them all, but you'll have heard a lot of them. And remember, they're neuroanatomical, and often the nuclei aren't apparent to you with gross visualization. So nuclei and fiber tracts, it can get very confusing, but what you want to be able to do is think about the things you can see grossly when you do a dissection of, you know, skin, what's in the skin, what's transmitting a sensation, where does it go in the cord, what does it do up in the brain, how does the subsequent motor response get generated. And it's not going to be important that you necessarily remember every nuclei involved, but you have to have a general idea of what the tract does, where the tract crosses, because it'll just help you, and it'll turn your screening exam into more knowledge that will build up your differential, your ability to distinguish problems. Now, like I said, in the undergraduate setting, grasp the basic stuff. You want to do a thorough exam, but you just don't want to get caught up in the jargon of neuroanatomy, neurology, psychiatry, neurosurgery. I mean, it can be bewildering. You want to, at first, just think about the structures you can see. Don't worry too much about whether it's in the lateral medial lemniscus. Eventually you'll get to a point where you'll understand the tract, and you may not even remember all the nuclei, but you'll be familiar with the posterior tracts, the dorsal column, etc. And you just have to have faith in that. You're just not going to be able to absorb all the minutiae. So the key to a screening exam, this is what John Chaney used to say. He was the coach of Temple's basketball team. He used to say, hard work broke talent's heart on many a night. And the thing about your screening exam, to get good, is just to be able to do it over and over again and to be familiar with how to do it. Now, I'm going to give you a simple list that you'll be able to build on, but what you need is practice and repetition, okay? Memorizing nuclei is not really going to help you that much. Of course, if you go into neurology and neurosurgery, you're going to have to know the nuclei, but right now just think about the tracts. Last week, John mentioned that he remembered as a medical student, Sidman and going through all the tracts. And those tracts are really valuable, and they help you think schematically. And once you can draw them out and know where things cross the spinal cord or in the brain, you really understand how to localize the problem. Because remember, the reason you're doing the neuro exam is that it's a screening exam, and the idea is that you're going to be able to localize a deficit to a particular area of the neuroanatomy. You know, it's very rare to have more than one culprit. It's all, you know, common things happen commonly. So if you're doing an exam and you think this person has 3 or 4 different diseases going on, you're probably off base. You want to be able to localize clinically to a clear, crisp area of the anatomy. And you'll determine that by knowing where the tracks run. Okay? Let's see. All right, so here's your screening exam. Okay, this is really simple. And you can have, you're going to have the slides. So think of handedness, whether they're right or left-handed. Traditionally, when you present a patient to an attending, what you want to hear is age and handedness. So 35-year-old right-hand dominant male. Now, just start with the handedness, then go to orientation. Now, orientation's a big general term, and as you get more into neurology, you'll be able to explore what's called executive or higher function versus lower function. But orientation is basically, date, location, time, day of the week, the year, who's president. When I was a resident for the kids, you just ask them to name the Mutant Ninja Turtles, and if they could name the Mutant Ninja Turtles, they were pretty much on track. Now, speech will become much more involved, and you'll learn more about speech as your knowledge progresses. But at first, you want to listen to speech, and you want to hear the understand the content of the speech. You want to hear the fluency of the speech, and you want to test both the expressive and conductional aphasia. So when you examine a patient, for instance, you say, please put your right thumb on your left cheek, or close your eyes as tight as you can, grit your teeth, raise your eyebrows, and see that they understand. So that's, to make sure that they have they don't have a receptive aphasia. They can listen to a command and perform that command. Neck stiffness. Now, that's an important issue too, because you want to check for meningeal signs or signs of meningitis. You want to check the range of motion in the neck. That's a pretty easy exam in an awake patient. I mean, you ask the patient to touch their chin to their chest and to look up like they're going to catch a fly ball or lean their head back as far as they can. Then you've tested the range of motion in the neck in the coronal plane. Then you want to test the range of motion in the neck in the axial plane. So you're going to ask them to turn their head all the way to the right, all the way to the left. And you know that with infections like meningitis or even viral meningitis, you're going to have what we call nuchal rigidity or tenderness of the meninges. Next is cranial nerves. That's a big topic too, but remember the screening exam, and we'll talk about that more in a minute. Then you're going to test the upper and lower limbs, okay? All right, so here's your orientation. Year, month, day, date, where are you, Mutant Ninja Turtles, who killed JR, or whatever the current, common knowledge is today. And of course, with kids, you got to be well versed in your Nick Jr. or Nick at Night shows. All right, now with speech, it's like I said, you want to check them for an aphasia. If they have a receptive aphasia, they're going to hear you talking but not be able to make any sense of it. And an expressive aphasia is the opposite, where they produce sounds and it's really just like what we call a word salad. Then you have them speak. Red fire engine, yellow tack, taxi, black cat, red ball, green tree, whatever your routine is. More advanced things like the prosody of speech, which is a non-dominant temporal lobe finding or localization, those are something for later on. You just stick to the basics right now. The neck stiffness we've already spoken about, the coronal or flex X, and the axial or left or right planes. All right. All right, so now with the cranial nerves, I mean, you could waste a tremendous amount of time on every cranial nerve. Remember last week I mentioned to you that think of the brainstem, and basically you're thinking of the midbrain, the pons, and the mesencephalon. Okay, midbrain, pons, medulla. The cranial nerves are conveniently and easily split into 4 cranial nerves per level. Okay, so your first cranial nerve and the optic nerve are above the midbrain, but the 3rd and 4th nerves are at the midbrain. 5 through 8 are in the pons, and 9 through 12 are in the medulla. Okay, so you'll frequently see cranial nerves 2 through 12. I kind of disagree, and that's what these asterisks are for. Okay, this is just my opinion. I think cranial nerve number 1 is often ignored and frequently injured, and I think it's the most frequently injured cranial nerve, and it's really easy to detect. For instance, there was a medical student, and he used to keep a little vial of cloves and one of, what do you have, cloves and coffee and one other thing. And, you know, he would ask the patients if they could distinguish smell, because, you know, with smell, there's a lot of things involved. Smell is responsible for a great deal of the sensation of taste. And it's important to know, especially in people that have a frontal lobe trauma or that kind of thing. So cranial nerve 1 is a really easy one to just do. Now, with the pupils, you look at the eyes, you look at the pupils and describe them, and you check the visual fields. Now, you can get that down to confrontational fields where you're holding up fingers, and you could do that in a few seconds. The fundi, or the papilledema, I have to admit, I don't check this all that often. As a consequence, I'm probably not as good at recognizing papilledema early on. Anybody can recognize it when the nerve head is really swollen, and that's often an indication of increasing cranial pressure. And with the pupils or the eyes, you want to check not only the visual fields, but you'll have them follow your index finger, and you'll hold it in all different spots and make sure that the eyes track well in all fields. Then you can just do facial movements, close eyes, lift eyebrows, show your teeth. Now, upper limb, lower limb, you're going to check tone, power, reflex, sensation, and coordination. You're always going to do that in your motor assessments. The tone of the muscle is the resting state of the muscle. So you know what a normal tone is like, and you know that in people that have had things like upper motor neuron problems are going to have greatly increased tone or rigidity. People with lower motor neuron problems often have flaccidity, like in a stroke. Power is a standard measurement from 0 to 5, and I'll talk about that in a few minutes. The reflex, you don't need to check every reflex. When you first do a screening exam, you can check the biceps, triceps, and the brachioradialis in the arm. You don't have to do every single reflex. You can check sensation, and the importance of sensation is to distinguish whether you are getting dorsal column, which is proprioception and vibration, versus pain and temperature, which is in the anterior. And coordination, of course, is kind of a cerebellar to brainstem link. But you'll get better. You'll get better with that with time. All right. Okay. So now you've concluded your screening exam. Okay. Now, if you can get that down to, the 3 to 5 minutes, which you're not going to do it at first. It's going to take a little longer, but you just can't be intimidated by it. You don't want to go in the room and just do an exhaustive exam because you just can't. You can't think of the fundamentals. So what do you do now? You've conducted this exam quickly. So what's the next thing you want to do? Well, you want to focus mostly on the pertinent positives, the positive findings or the abnormal findings on the exam. And as you get more knowledgeable about important normal findings that would steer your differential one way or another, you'll add that on. But first of all, think of the pertinent positives, then try to present the patient and their problem in a really organized, concise fashion. Remember the 90s, there was a television show, Twin Peaks. It was a very confusing plot, and a lot of times you'll fall into the habit of Twin Peaks presentation, which gets you all over the place. You really want to keep things short and concise. And like I said earlier, age, handedness, sex, then the problem, how long the problem's been going on for, the physical exam, etc. But you should be able to do just a few sentences, and that does take a lot of time. And as you learn more, you'll know what's more important and what's less important. So at first, it's good to have a short differential that you keep in mind. And it's better to think in terms of a general process rather than specific disease entities. Like, for instance, demyelinating disease rather than just a specific disease, like, say, multiple sclerosis. So you could present a patient and say, well, I'm concerned the patient has a demyelinating disease, or you may be concerned that they have a progressive neurological disease. You want to think in terms of motor, sensory. You want to think about what's involved. So as your understanding of the physiology improves, so will your differential diagnosis. And you always want to keep in mind that the common things are what happens commonly. If you're diagnosing exotic diseases frequently, you're probably not thinking as clearly as you should be. Now, also remember that in different areas in the world, there are different disease incidents. So I did neurology in Britain in the early 1990s, and a lot of the students, like the students from India and Pakistan, they were so used to seeing sarcoidosis in the brain, like they knew that inside and out. I had never really even seen it before.
Wow.
And you know, the German students were used to seeing other variants of things, so you kind of learn from the patients that you're exposed to. Okay, so like I told you before, global to granular. The reason is that you want to practice your repertoire and get it down so you can start doing more specific. You can start doing more specific general exams and looking at the things you know, and then gradually delve into the things you don't know. For instance, I put a few slides sets away with links that you can look at, and I think that these are really good talks by other people, but you'll see within 2 slides you're going to have seen so many terms that you're unfamiliar with. And that's hard for an undergraduate or less advanced person to assimilate all that information. You're going to hear terms like Pacinian corpuscles in the skin that conduct sensory. All you have to think about at first is not what particular mechanoreceptor is transferring the stimuli. Just think that, you know, there's a sensor in the skin, and that's the first motor, that's the first neuron on the way up the path. And as you can understand, that sensory paths are ascending pathways. They travel up the spinal cord. And the descending pathways go from brain to extremities. Those are the motor tracks. Let's see. So like I said before, low magnification to high magnification. If you're looking through a microscope and you start on the high mag, you're completely lost. But if you start on low magnification and then drill down to the detailed things, you'll be much easier oriented. It's bewildering to start with the mechanoreceptors in the skin, build out, and then into, you know, larger scale and then go up the track. Drill down. So you want to think of your neuroexam as modular, and as you get experience, you'll then recognize what components aren't indicated. Now, I have no financial interest in this whatsoever. On the iTunes App Store, UCSF, University of California, San Francisco, produced a neuroexam app or tutorial, and it's really excellent because it's dynamic. You can watch videos, and it will really help you sharpen your neurological exam, and that they will show you an exam so you'll get used to seeing how to conduct the exam, and then you'll have to judge what's abnormal, what's important, what's not important, and I think this is really excellent. I wish I had something like that when I was a medical student, just because it's dynamic. All right, so here are the source materials. Now, these are just my opinions. There are so many books on the neurological exam. It's bewildering. And you don't really, there's so much information on the internet and in your lectures that if you concentrate on incorporating that first, you're fine. But here are some of the really good source materials I've seen lately. Really, the first one is called the Neurosurgery Handbook, and that is the work of Mark Greenberg, and he's been putting that out now for about 2.5 or 3 decades. But there's a really great book with bibliographies on just all kinds of minutiae that really help to organize things well. Then Remy Nader is a very prolific writer. He's a neurosurgeon. He's now in Texas. He had been in Mississippi for a while, but Remy has written a lot of books, neurosurgery, board reviews, all kinds of good handbooks on neurosurgery. He has one called The Essential Neurosurgery Companion by Gaston Nader. And this is a really good book if you want to go into neurosurgery. It will teach you about many aspects of the exam, and one of the most important aspects as a neurosurgeon is examining a person with a decreased level of consciousness and that kind of thing. Another good one is the neurological examination by John A. Goodfellow, and I already mentioned the UCSF NeuroExam app on iTunes. Now, there, like I said, are just a tremendous amount of books. I mean, you could read dozens and dozens. Some are good, some are a little more esoteric. The recent book I really liked is The Anatomic Basis of Neurological Diagnosis. This is a really good book to just understand graphically what the neuroexam is telling you and how to localize it to the proper area of where the lesion is. So this was written by Alberstone and Dr. Benzel, Najm, and Steinmetz. These were principally people from the Cleveland Clinic, and there's a foreword in it by Dr. Roten. Then another book is this Localization in Clinical Neurology. This is more of something for a neurologist. I have an old edition, it's like the second edition. I think it's out to like the 6th edition now. And of course, the changes aren't anatomic. The changes are in technology and the ability to see things that you couldn't see before, like tractography and that kind of thing. But Dr. Bill really helps you think through different schema to arrive at a clear-cut point where certain neurological deficits are going to evolve from in an anatomic standpoint. Now, these are two other important things. One is this book is called The Guarantors of the Brain, Its Aids to the Examination of the Peripheral Nervous System. This is a really thin paperback book that it's been produced for many generations, and it's just how to examine the peripheral nervous system. When I was doing neurology, someone at Queen Square said, a professor said, I just don't remember her name, but she said that the peripheral nervous system is probably as complex as the central nervous system. We just don't understand it yet. And that may actually be true. The peripheral nervous system is a difficult exam. Dr. Spinner from Mayo has a very good, small, concise book on the peripheral examination. In some ways, you can also look at how the orthopedists distinguish extremity movements and localize it. That's an art, and you've got to, like I said, start with the basics. Learning just the brachial plexus examination is difficult. So, also from the Queen Square, they have this test for cognitive deficits. It's like at 10 pounds or 12 euros per copy, or there's a free alternative, and that's the Addenbrooke's Cognitive Examination, and you can get it at this website and just download it. And I think, honestly, that's more than enough for a non-specialist right now to do this exam. It's free, and it'll give you a better understanding of cognition and what is often termed higher executive function or executive function.
Very good, Richard. Thank you for another excellent presentation. We'll open it up for questions. I'm sure people have a lot of questions. Go
I
ahead,
got
Richard.
a couple more.
Okay, I'm sorry. Go ahead.
Is that all right?
Sure.
Like I said, there's tremendous amounts of material, okay? But all you have to do is just think of the building blocks, the things that are visible and tangible, how you touch the patient's skin, whether you give them a vibration, fine touch, etc., and how that tract develops. Like I said before, Dr. Bennett mentioned the Sidman and Sidman book on tracts before. I'm going to just show you a brief look at what's called the dorsal column medial lemniscus pathway. And I'm doing this on purpose so that you get an idea of how much easier you can make it for yourself. So here's the dorsal column medial lemniscus pathway. That's a pretty intimidating name. And Dr. Ahmed has this really nicely illustrated slideshow, and I've given you a link to that. And within 2 or 3 slides, you're going to have seen so many minutial facts about skin receptors, mechanoreceptors, Passonian granular receptors, all kinds of things that I think you get lost quickly. So what I want you to think about is just the sensory pathway where you touch an arm or a leg and how that travels up the cord. You can get into the exact minutia of that slowly. You don't. I think if you submerge yourself in that immediately, you really are going to struggle. So what is the dorsal column medial lemniscal pathway? All that does is it traces the path of proprioception, which is where where something is in space, from the joints and the muscles. It travels up the cord to the thalamus. And then from the thalamus, it spreads via the internal capsule to the postcentral gyrus, which is also a term for the primary sensory cortex. And then it's processed, and then you're going to initiate an ascending pathway. And when you look at these diagrams, it'll make much more sense to you. Look at the trees while they're bare with no leaves on them. See the important branches, and then you can add the leaves and foliage later. Otherwise, you're going to be encountering new vocabulary constantly. All right, so I think we're just about. Oh, I had one more slide. It was an advertisement. I think I left all 4, but I'll show it to you next week. It's not important. All right, so what can I answer now? Or, I want you to have the slides. You're welcome to. And like I said, I would like you to look at it when the trees are bare. Just look at the general pathways. Don't try to remember 9 different mechanoreceptors in the skin and whether they're going to Golgi tendon organs, or just follow the track up the spinal cord into the brain and then the deep tract. And I'll go through a couple of them next week. I think this can be very dry. So what I'll do is try to present you some cases next week, and then we can kind of integrate the cases and the findings. Then it's a little more interesting.
Okay. Okay, Richard, just click on the green arrow to get off the screen share so we can see your face, and we'll open it up to questions. Lisa, do you have any questions you'd like to ask Dr. Mandel, or any comments on his presentation?
Yes. What would you say about the assessment of gait?
That's an excellent question. You're gonna develop gait and speech are really complex, and gait in the pediatric setting is very interesting, and that's something that you see a lot in pediatric scoliosis surgery. The gait itself, what you want to look at is stance and swing phases of gait. Okay, stance is when the leg is planted. The swing phase of the gait is the other leg that's in motion. So you want to see if stance and swing are symmetric and fluid, or not spastic. Gait will tell you a tremendous amount of information. For instance, one of the really clear markers of Parkinsonism is the loss of arm swing with gait. You'll notice that people with Parkinsonism often will walk in a somewhat stooped or kyphotic posture, and they'll have very little arm swing. The other aspects of gait, of course, is the interplay with balance and equilibrium. And for instance, in children, you want to be very attuned to watching kids walk, especially kids that are walking, really without their heels, more up on their toes. It's often a concern that you have with the myelodysplasias, like, Chiari malformation, or, incomplete neural tube defect. And you'll build on that. But yeah, gait is important, and not only from the neurologist standpoint, but you can watch some of the pediatric Scoli people that'll often have a gait analysis lab that they put the kids through when they're working them up for the scoliosis. So that's a multidisciplinary answer, but it's something you can focus on a little bit more later, just like the peripheral exam, the exam of the brachial plexus, the exam of gait, the exam of speech. So yeah, gait is very important. For instance, I'll give you a very good example. Oftentimes you'll look at people and they'll have a really very awkward gait where they lift their legs up very high, a high steppage gait. And you'll think, boy, what's the problem? And it could be a very simple problem. It could be something like a peripheral neuropathy or bad diabetes where they've lost their proprioception or knowledge of where the leg is or foot is in space. So they lift the leg up real high and place it down, and it's really a dysfunctional gait, but it's really due to a far distal problem rather than a central problem.
Okay, Simon and Ben, do you have a question?
Yes, please. Thank you very much, Dr. Mandel, for the presentation. As you were saying, it's a great deal of information. I can see that I'm going to have to look at this again and again, and it's great that we're taking it in small bites. You touched on some points that made me remember my brother. He's an orthopedic surgeon, and he went to UCSF, and during his residency, we were living together, and he was working at Shriners Hospital.
Yeah.
And he introduced me to the concept of gait, and I'd never really thought about that and didn't know what the word meant when I first heard it. But I was wondering, do orthopedists and neurosurgeons conduct neural examinations in different ways? You touched on that a little bit, but I wonder if you could tell me a little bit more about that.
Well, yeah, it's funny you mentioned Shriners. Actually, their headquarters is right here in Tampa. But Shriners, that's wonderful for kids. And the orthopods who work in, the Shriners facilities are usually top notch. Orthopods tend to play dumb a lot, and they don't really want to get too involved with the neuro exam because they're often very, very goal-minded. A lot of engineers go into to orthopedics. Orthopods, look to solve a problem, to fix the problem. And so, they try to separate out early what they can fix and can't fix, and they focus more on mechanics of gait rather than neural control of gait, which is fine.
Mm-hmm.
But they've really pioneered pediatric scoliosis. There are neurosurgeons that do pediatric scoliosis, but if they're good, it's because they train with really experienced orthopedic surgeons that really pioneered the field since the 60s. The Scoliosis Research Society used to be all orthopods, really.
Okay, a couple comments, Richard. Yeah, I can't stress the fact that Sidman and Sidman helped me a lot during medical school to simplify. Because when you're a student, I don't know if you remember back then, it's such a daunting thing. Neuroanatomy, you have anatomy, which is pretty straightforward, then all of a sudden neuroanatomy, where it seems so complex. But Sidman and Sidman helped me digest it. And I know when you mentioned about the ER, the neuro exam is so important. I worked like 20 years in the ER, and it was so important to do a rapid neurological assessment because you had to determine fairly quickly in some instances when you have a multiple, like a car accident, you had 3 or 4 people, that you had to determine very quickly who needs a CAT scan, and who needs testing, and who needs just to be monitored. So certainly something like this 3 or 5 minute assessment, you really got to be good at it.
Yeah, you really do, because that's one of the things that has driven a lot of problems in medicine. It becomes almost necessary to scan every single person, even if they don't have any clinical findings. And in the rest of the world, where not as much, like for instance in Britain, they really want a good screening exam. Preoperatively, there was a patient once who was a very intelligent guy, like incredible IQ. He was a systems analyst somewhere. He had a frontal lobe tumor, and I was asked by my attending, what should we do to screen him before surgery? I'm like, well, we could do an IQ test. He goes, you Americans, you just spend so much money. And then I think it was either Charlie Gordon from Tyler, he's in Tyler, Texas now, or might have been one of the other guys I was rotating with. They said, well, why don't we just have him do the Times crossword puzzle? And that was a great idea. And the guy did it in 8 minutes. And then post-op, the first week, we gave him the Times crossword puzzle, and he did it again in 8 minutes. And they figured, well, it's good enough. So, yeah, you want to be more resourceful, and you really want to think about how you have to scan every single person. And because of the environment, the answer is probably most of the time. But you want to have a good feeling who really needs attention and who doesn't.
Well, my brief neuro exam in the ER consisted of, first of all, I would ask the EMTs what happened. I try to get an idea of how did this person hit their head? Did they fall down or whatever? And then I would, the appearance, look at the person, check their head, look at their pupils, move their neck, ask them to grab my hands, grip strength, and move their legs. And that was, we had to be fast to determine if did it need to be scanned or not, or can I go on to the next person?
Yeah, I mean that's I think that's correct, and you just have to have confidence that you are doing a well thought out exam, that you're testing all different points. Why don't you think about this? But next week, why don't you tell me what you think you can do in terms of the neuro exam without touching the patient? I mean, there are a few things you can learn just by watching them and walking into the room, right? Mm-hmm. I mean, you know things already about their level of consciousness, and you asked last week about mnemonics. There are so many different mnemonics, but they're useful for some things. You know, when you talk about a patient that has had a change in mental status, the mnemonic used to be TIMES: toxic, infectious, metabolic, electrical, structural. And that really does cover the vast majority of everything you need to think of. So
Okay.
you just have to kind of get ready for the various complaints. You have to understand how to work up dizziness, how to work up headache, how to work up a movement disorder. That's, you know.
Well,
And
you
you
know,
learn that. You'll learn it as you learn more neurology.
well, I know in the ER sometimes it was important to do serial neuro exams to see if there's
Yeah,
a improvement or deterioration in that person's neuro status.
yeah, that's why there's ICUs. You have to follow somebody closely. You want them in an ICU where the caregivers, which are primarily the nurses, are watching for any changes.
Right, right. Okay. Okay, Ben, do you have any questions?
I think just to make it. I mean, I know a nervous system is so complex to examine, and first thing we have to know in neuro exam is, what is the urgency of the situation. First
Exactly.
things, and
Yeah.
then from there I mean, we have to prepare ourselves whether to do a quick exam or whether to, whether it take. I mean, whether we can, it takes some time, because time is urgency here.
Right.
Just like trauma, I mean, you can't touch the neck. And also in toxicity, you have to know what's really going on with this guy. I mean, whether it's really conscious or is going to, you know, is really dangerous. If it originated from AFib or something like stroke, we need to be even careful, because the treatment needs to be started right away. Otherwise, the patient might develop stroke and those kind of things.
Hmm.
So, I mean, before we approach these patients, I think we need to think globally, and
Exactly.
and
Exactly.
focus our exam as it needs, and as it demands.
Yeah, you want to think of immediately. You want to think of the important thing to rule out, and then the level of consciousness. I mean, you can be in ERs 3 o'clock in the morning. 30 people are in there in the waiting room just because of back pain. You have to be able to prioritize, and you've got to know. This is what Dr. Izzo used to say. You've got to know. All you have to do is figure out who needs help, who's sick, and who's not.
Right.
You're in a hospital, there's lots of smart people around. If you can just figure out who needs attention, you're in good shape.
Yeah.
And
That's definitely true in the ER. Definitely.
yeah.
Definitely. So, okay. Any more questions from the panel? Okay, very good, Richard. I guess next week we'll continue. I guess the topic. Do you want to tell us the topic now, or you want to think about it, or?
Well, I think that we ought to just do a few sessions of pertinent neuro exams. Like
Okay.
I don't want to get into really esoteric findings.
Okay.
Let's do some common things.
Okay.
It'll help you guys localize and think anatomically, and remember the KISS principle. Don't outthink yourself. Don't focus in too much
Mm-hmm.
before you get your foundation and your groundwork. Remember the first couple questions of the exam. Are you right-handed or left-handed? How old? The sex and the presenting symptom. And you want to condense it down. That's
Mm-hmm.
all. And the last thing is, you can't be thin-skinned in neurosurgery or neurology. Your examiner is always going to ask you questions to test where your knowledge ends. And you can't get upset that you missed the question. You're going to miss questions for years, but you'll get further and further along each time. that just gauges where you have to begin again from.
Very
Okay.
good. Okay, we'll wrap it up now. Richard will hang around a little bit and chat. Thank you again for a great presentation, and we'll be seeing you next Saturday for the continuance of the neurological exam. Thank you, everybody in the panel. Thank you, everybody in the
Thank you,
panel.
Dr. Mendel.
Sure.
Thank you.
Okay, we're going to sign off. Thank you very much, and vote for Ben Carson for president.
Yeah.